on alignment philosophy in TKR?
I think it's interesting in medicine and life in general.
Hello.
You have to learn, unlearn and relearn. That's what's happening with alignment philosophy. It took me 10 years to learn that in TKR you have to get this alignment. Now I have got to unlearn and then relearn. Very tough.
A very good morning. I hope I'm audible. Can't make out much with the mic here. I think the mic isn't great. So let's talk about alignment. My job today is to try and explain very, very basic concepts of alignment, and I think 6 minutes is way too less a time to talk about it. Having said that, we know that we've all been following mechanical alignment for a very, very long time, and I would still say that mechanical alignment remains the gold standard. This is initially, we started off with two thoughts. The first thought or the first idea was anatomical alignment, and then there was another group that talked about mechanical alignment. The anatomical alignment moved to constitutional and sort of kinematic alignment, and the mechanical alignment through sort of measured resection, gap balancing, to now functional alignment. Now, before we can talk about any alignment philosophy, there are two very basic things that we need to know. The first is that no alignment talk will be complete without LDFA. So if you do not have a way to measure the lateral distal femoral angle on your patient's X-ray, there is no point in going ahead talking about any alignment philosophy. We know that LDFA is not 87 degrees in every patient. We know that the joint line tends to slope by 3 degrees, but as we do more and more robotic cases, we see there's a huge variation in the lateral distal femoral angle. The second most important thing that you need to know is the MPTA, or the medial proximal tibial angle. Again, it's not always 87 degrees. The tibial joint line does not always slope at 3 degrees. And the anatomical axis and the mechanical axis of the tibia, as we've been told, is always the same, is not always the same. There are huge variations. In fact, I would say rarely, very rarely would you find the anatomical and mechanical axis in a patient that you're doing a TKR. Now, the big question is, why are we talking about all of this? And I want you to look at this image. This image, all of this comes in from the CPAC classification, but I want you to focus for a second and look at the image with the HKA shown in red. And I want you to see now, so you've got a knee that has an LDFA, which is 87, and MPTA, which is 87. Now, you have a knee which has an LDFA of 90 and MPTA of 90. And now you've got something which has an LDFA of 93 and MPTA of 93. So if we go back with the same HKA, you have 3 different knees. The idea is that we identify which knee type we are operating, and we try and reproduce the native anatomy of that knee with regards to the LDFA, MPTA, and the joint line obliquity. If this is what we are attempting, then we are actually doing what all these alignment philosophies are conceptually based upon. The next thing that comes forward is the arithmetic HKA, which is different from the mechanical HKA that we've been talking about for a very long time. The arithmetic HKA is supposed to give us the native sort of varus that the patient had constitutionally. Obviously, it cannot be measured when there is a huge amount of bone defect, etc., but that's conceptually what we need to know. With the limited time I have, I cannot go into much detail, but essentially, if we know the LDFA, the MPTA, and we calculate the AHKA and the joint line obliquity, we know what CPAC type a patient is, and therefore we can try and reproduce that native CPAC type, keep the patient in the same alignment that the patient had prior to surgery. We do not, however, none of these calculations take into consideration the joint line convergence angle, which is a big problem in our patients. There's a huge amount of joint opening, which is the soft tissue laxity component, and therefore, while this calculation shows an AHKA of 0, the patient has 5 degrees of varus. Again, I cannot go into details because of shortage of time. So let's look at where we are. On one end, we've got mechanical alignment. On the other hand, we have kinematic alignment. I'll skip this slide again for shortage of time, and we'll just sort of go on to onto this image. So what we see here is this gentleman in the center. Now the question is, he's active, he's athletic, he's still playing. He comes to us for a knee replacement. What is it that we want to offer him? Do we want to make his knees straight? Do we want to keep his knees back to the same way as they were when he was active? And that's exactly the whole concept between mechanical and kinematic alignment. So the proponents of kinematic alignment believe that we should restore what the patient had, and the proponents of mechanical alignment want to change the alignment. Now the big question is, we all know that if we try to make this leg completely straight, it's going to involve a huge amount of soft tissue release, and this patient may not be that happy. So what is it that we're trying to reach? What we're trying to reach is neither, I think, in today's time, neither reach complete kinematic, so we restrict our boundaries to safe limits, nor are we going completely mechanical to make it completely straight. So we work within limits to sort of get, essentially, minimize our soft tissue releases, and adjust our bony cuts to within safe limits. So the kinematic philosophy moved to restricted kinematic, the mechanical alignment actually moves to sort of not exactly adjusted mechanical, but in the end, all of us are aiming at a more functional alignment, and that's our objective. So in the end, I won't go through what functional alignment is through want of time, but I think in essence, the consensus is that you adjust your bony cuts within safe margins and minimize your soft tissue release. That's what, in my opinion, the consensus statement with regards to all alignment philosophies is. Thank you very much.
Thank you, Dr. Mudit. It's going to be a very interesting session. I think we'll have a discussion at the end of the session. Please just take a seat. May I now invite Dr. Saurav Shukla to tell us about his experience with VALIS, with kinematic alignment. Is Dr. Saurav Shukla here? Right. Next is Dr. Mukesh Ladda. He's going to talk about alignment philosophies and soft tissue correlation in TK.
Good morning, everyone. So Dr. Mudit Khanna kept rolling the ball, and we are here to get screwed by all these stalwarts here. So let's go. When I started, this is a new article came just recently in 2013, and a good video promoted by Ortho TV, that after spending so many hours in alignment understanding, it's still like a Devdas what to do. Nothing, no one is with you. So let me take you to some philosophies. We know mechanical alignment has worked well and has not worked well as well in many of our cases, and in most of the cases it worked well. So what bony cuts we take in mechanical? We go perpendicular to the mechanical axis of femur and tibia, and then we start releasing the soft tissues to balance the knee. There was another concept of anatomical alignment, where you put the femur in 2 or 3 degree of valgus to the mechanical axis, and tibia in 2 or 3 degree, and then the rotation on the posterior condylar axis. That's the anatomical alignment. I'm talking about bony cuts right now. Then came John Bellarmine's paper that there is something called as constitutional varus, and it is unnatural to put the knee straight in those some 32% of patients. And there comes the kinematic by Dr. Professor Howell, who says that cut the distal femur 9 mm as per the thickness of the implant, posterior and distal femur, and then keep balancing it as per your tibia cut. But that sounds scary, because more the tibia cut, we know it will lead to aseptic failure and the tibial bone loss. And they may be working well with Professor Howell in his hand, because in US and other, their patient comes very early. They don't come so late the way they come to us. So I think whenever you feel like the kinematic alignment has to be done, I think they are ideal patients for unilateral knee replace or partial knee replacement, because you have to do no releases. But Professor Howell has found a good survivorship of about 98% at the end of 10 years. Not only he, various other articles have said that the patient are most satisfied with that kinematic balance compared to mechanical alignment. That may be little controversial. So people thought then, if the cutting tibia is too scary, let's do it reverse. Keep tibia at 90 degree and keep balancing it on the femur by increasing your distal femur cut or by increasing your posterior femur cuts, and then by rotating the femur. Again, putting one bone normal and working on the other bone. Then something came restricted kinematic. You do all calculations pre-op, how much is the HK angle, how much is the MLDFA, how much is the MPTA, and play within the range so that you can get the pre-arthritic level. All this is possible with help of some instrumentation. It's very difficult to get that conventionally with the things. So all these papers which were done previously, they have done either on the patient-specific jigs, or they have some PSI, or they have done something on MRI and all that, and then they have done all this. And then came, this is the flow chart for restricted kinematics, modified kinematics where you just rotate it. Then came the functional alignment where you play both on the femur and the tibia and the soft tissue. So I feel mechanical is still people are using. Next is what functional alignment will work well, because knee is made up of femur, tibia, and soft tissue. So why only to make one thing at risk? Like in kinematic, tibia is at risk. In inverse kinematic, femur is, you are cutting more. In mechanical, we are doing a lot of soft tissue release to balance the knee. So this is what the limitations of functional alignment are. You cut the distal femur within a range of about 2 to 3 degree varus to valgus. Same for tibia, 2 to 3 degree. The whole HK axis should not go beyond 4 to 5 degree of varus. And the same way you balance with the flexion and extension gap. But for all this, you need some technology. It's extremely difficult to follow them conventionally. So this is the main topic which I want to show. In the red, how you balance in mechanical axis, knee balancing, you need frequent soft tissue releases if you do mechanical alignment. What kinematic balance is that don't do any soft tissue release, which is quite scary because it's not possible only to keep cut tibia and balance the knee. In inverse kinematic, they say don't do any soft tissue release, but in restricted and functional, you need some soft tissue release with femoral and tibial component in expected or acceptable range of, you can't put femur in 5 degree of valgus, you can't put tibia in 4-5 degree of varus. You have to be something within a range, say about a couple of degree varus on the tibia, a couple of degree varus on the femur, that automatically opens your medial gap, and that reduces your soft tissue release. I'm not saying that this alignment, I don't believe that you don't need any release if you do kinematic. I don't believe that. There are some situations where even after doing functional, you have to do release if it's a very stiff knee, not correctable under anesthesia. So you have to take it with a pinch of salt, but most of the cases with functional alignment, you may go up without releasing if you put them in a proper and measured angle. So another article which says that functional alignment achieve more balanced total knee arthroplasty than either mechanical or kinematic prior to soft tissue release, because if the tibia and femur is varus, and if you put femur in 2 degree varus and tibia in 2 degree varus, you will see it automatically opens your gap, and that reduces your soft tissue releases. So if you have, many of us see this patient, now she has a varus thrust gait, and other side she don't have that much of varus thrust gait. Now if I plan mechanical alignment on that severe varus thrust gait, I know I have to do a lot of releases to balance that knee to the lateral side, which is a lax one. So what I did one side mechanical and one side functional. This is an intraop pic where you can see that I have not touched the posteromedial capsule at all if I am going for functional release, but if I do mechanical release, I have to do, but both of them had given me a well-balanced gap throughout the range of motion. How does it affect? So you can see this, the well-balanced full extension. There is no medial opening at all under anesthesia, even on the full extension, as well as even on the anterior-posterior if I am using the pressure. The same other knee, there is some slight 2 or 3 millimeters of medial opening in the mechanical alignment because I have to balance with a lot of soft tissue releases in those bad knees. So what I mean to say, you have an excellent balanced knee, but then less soft tissue releases occurs with functional alignment compared to mechanical. And if you balance them well, patient have very stable knee, they can even dance and all. You can't stop patient from enjoying his life, but the stability with reducing the soft tissue releases is much better than getting the stability with with extensive soft tissue release. So here, functional alignment gives you minimum releases. I'm not saying no releases, but that helps you to reduce the releases. You can do that even in this complex case where you have 25-year-old implant done, difficult to remove, you can use your CR technique, you can use this, you can put the femur and tibia in 2 or 3 degree of varus, rotation, flexion and all, and you can see the lower graph from 0 to 120, it's well balanced throughout the range. So I think functional alignment reduces soft tissue with minimum cuts. Thank you.
Lovely. Thank you very much, Dr. Ladda. Is Dr. Saurav Shukla here for his talk? Otherwise, we'll move on to the panel discussion. I guess not. So I think this whole concept has come up only in last 5 to 10 years. Let's have a quick show of hands. How many of us in the audience have access to robotics or navigation? So I would imagine what, 20%? 5%. No, there are some people here. Yeah, so of the delegates, I think maybe 5% have access to robotics. I think this whole concept has come up only with the advent of robotics, that we start talking about 3 degrees varus and 5 degrees varus and not going beyond 5. Anybody with conventional technique tries to, say that I'm going to go for adjusted mechanical and I'm going to give 6 degrees of varus. How will he know that 6 degrees hasn't become 15 degrees? Because your human eye cannot make that difference between 6 degrees and 10 degrees and 12 degrees. So the problem is with using all these terminologies and using conventional techniques. Even with kinematic alignment, proponents of kinematic alignment today are proposing that for cases that are absolutely unsuitable for kinematic alignment, for the simple reason our deformities tend to be much bigger than 10 degrees and 15 degrees of varus. Majority of our knees tend to be much more than 10 degrees of varus, and they are actually not suitable for kinematic alignment. So any burning questions from the audience before, or we can ask our own questions? Yeah, please.
Yeah, so we keep talking about the kinematic alignment or the functional alignment or adjusted kinematic. Are the implants suitable for that? The only 2 implants that I know which are suitable for that are the Journey 2 and the one from Implant Cast, the primary. If we plan to put a normal symmetric inlay, sorry?
Even Journey 2 is not.
Journey 2 has a wider lateral gap. It has both variants, a kinematic poly and a normal CR poly. So with us it is available. So you either can, so these are the only 2 implants which are available, and as far as I know, the anatomic alignment, which used to be almost the norm in the 90s, failed miserably due to this one reason.
So that's the answer, because initially why we went for mechanical is to have an equal load distribution. The poly quality was an issue in the previous days, but nowadays the poly quality has also improved.
We are trying to work with the improved poly quality, assuming that the improved poly quality is going to account for the variations or the increased loads that kinematic balancing is going to place on the medial side of the knee. And you assume, hoping that this poly will survive even if the knee is in 3 degrees or 5 degrees of varus. But those believers of unrestricted kinematics today are talking about 7 degrees and 8 degrees of varus. And when you talk about that, yeah, Mudit, you want to talk about that?
No. What I mean is, you've been very considerate to them by saying 7 or 8 degrees.
I'm just being conservative.
Yeah,
they're talking
so they would go anything. So I, that's why I don't think kinematic in its true form is actually practiced by anyone amongst us. Unrestricted kinematic in its true form is not practiced. I don't know of someone practicing it in its true form.
See, ultimately it doesn't boil down to the poly or the metal. It boils down to the variation in the joint line. Whether you place it in 7, whether you place it in 7, 8, 9, your joint line has to be balanced. Now your differential poly is taken, even with the Journey, is taken into consideration, or the design factors were taken into consideration given the fact that there could be an uneven laxity, which means the lateral opening up versus the medial. So that is again not for kinematic alignment. So if you're talking about implant specific for kinematic, that I don't think has yet appeared, and that is the biggest question that is doing the rounds even in the research circles. But again, it depends on the joint line. Ultimately, it has to be balanced. It only looks at the joint line variation, whether it's in varus or valgus.
Also, a small note about the McDessie paper, which Dr. Khanna cited about the CPAC. It took into account 250 young, healthy knees and described the alignment and the joint line obliquity in them. We don't know what happens after the youth till the arthrosis. So none of my patients come with scanograms from the youth.
Yeah, they will not. I think important.
So I think, see, you cannot take anything from, the concept is based on loss of cartilage, but no loss of bone.
Yes.
Okay, so you can predict what the alignment was as long as there is no bone loss yet. And all these patients who will have bone on medial side and no bone loss will actually be candidates for a for a UKR rather than a TKR. So yes, it is very, very difficult to use it in its true form. However, we know when we, if you've got an MPTA of 83, you know that, okay, and you can see that it's worn out just about, a couple of millimeters. You can make that assumption that, okay, it would probably be 86 or 85, and sort of keep the patient still in the CPAC, in the same CPAC type. So it's about using it smartly, not in its complete entirety.
Yeah, Mudit, the biggest objection to CPAC today is that any deformity, say more than 12 to 15 degrees, tends to all gravitate towards CPAC 1. And the wear that you have in the knee is not a two-dimensional wear, it's a three-dimensional wear. So what is the point that you take as a reference when you're calculating all these MPTAs and LDFAs? That becomes a huge issue, especially when the deformity develops beyond, say, 12-15 degrees of virus. And when the posteromedial wear develops, whether you take the bottom of the defect or middle part of the defect as your reference point, changes the CPAC classification.
No, I completely agree, and that's why I said the most important, are those cases where the bony defect has not yet come, and there is this high demand patient, bone-on-bone arthritis, who's walking, let's say 5 kilometers, his walking is restricted to 3, and he wants to go back to his 5-kilometer walk. So let's
have the...
One last question. What about the valgus knees?
Yeah.
Same
issues with valgus. In fact, much worse in that scenario. Much worse.
Yeah. I don't know patients who are satisfied with post-op valgus.
No,
Nobody would be, and that's why the aim all over here would be, basically we are dealing with fixed deformities, we are dealing with 10-20, and most of our practice, I'm sure everyone will agree, they come ready for a TKR only at a fixed 10-20 degrees, and there I think the more acceptable role would be towards a mechanical rather than this unrestricted kinematic alignment.
So it's for valgus, it's again, so we're probably deviating from the whole concept again, but for valgus we still want mechanical.
So just to answer this question, I just told him that
because
when
the tissues are
deformity is too
opposite
much,
side.
it's about the obliquity, not about the same MPT or LDFA. That's the concept with this. It has gone through. So my question is with Dr. Mukesh. So as you're doing either kinematic, restricted kinematic, or functional, so all these concepts are much more valuable in a CR knee, but you're doing all those PS knees. So you're basically cam post mechanism will wear out with time if the obliquity is too much. That's what the question running behind that. If I'm doing a PS knee, probably I should not be going towards the kinematic alignment, because that oblique forces on the cam post will probably break the post from there. That's the
joint line obliquity is very difficult to recreate in the TKR patient because of your poly, and if you are using CR, you can have something in obliquity, but in PS you can't. So that's why I'm saying kinematic or unrestricted kinematic is practically the ideal patient for UKR, not for total knee. So I follow mainly functional, where I just keep it within the range of 1 or 2 degree of tibia, 2 degree of VAR, and I don't want obliquity. Though they say get the pre-arthritic joint obliquity, but practically it's not possible. So balance it within range, 2 millimeter, 2 degree tibia, 2 degree femur, and then try to minimize soft tissue release. So you have to take everything, not only bone cuts, but respect the soft tissue. As in valgus, you said, we want mechanical, because again, the soft tissue on the medial side won't allow us to go into that varus. So we have to come with mechanical.
Yeah, thank you. So because that's what I wanted to point out. For PS knee, that's not the concern.
Trust me, an X-ray with 3 degrees of virus in the tibia can be passed off as an absolutely mechanically aligned X-ray. So it's a very minor variation.
It's important to ask, why has all this started? And this all started with that 20% patient dissatisfaction figure that came out with Bob Bone's paper. And that 20% is also unrealistic. In fact, in our practice, I would imagine that about 5%. Yeah, last question on this session.
The concern is that actually there are only two kinematic schools, the true kinematic and the mechanical. And the person who designed or defined the kinematic alignment, if you read his research, he has fantastic survival in all those varus valgus knees that according to mechanical alignment are outliers. So what my concern is that are all these alignment strategies actually a gift of technology and are urged to do some publications, and we are unnecessarily causing confusion in the young minds. Because we have been doing all this, the people who have used the navigation of Escolab way back in 2005, 2006, we used to play with the tibial cut and femoral valgus varus and all these things just to get a balanced knee. But we were not giving these different names, and if you read all the articles and all the alignment strategies,
so
they are
let me,
just playing with the
okay,
names.
thank
so,
you.
Like, is it right to say that we are like unnecessarily confusing the young orthopedicians by giving them a list of alignment strategies?
I want to make a comment on this. I think you raised a very valid point, and also Himmat raised a very valid point. Why are we even talking about it? It is that 20%, which is not 20% according to him, according to me 10%, are unhappy patients. So those unhappy patients are like an elephant. And there are 4 blind people trying to think what is the cause of this unhappy patient, out of which one blind fellow thinks it is alignment. Another one thinks it is patellofemoral, blah, blah, blah. So it's one about that. Second thing, in last 20 years, I have seen what I call TKR की आंधियाँ आती है TKR में एक हर 2-3 साल में एक आंधी आती है वो होती है हाई फ्लेक्शन नी फिर वो आती है PSA फिर वो आती है कंप्यूटर नेविगेशन ऑल दोस आंधियाँ अब ये आंधी चल रही है काइनेमेटिक अलाइनमेंट आंधी I think youngsters should watch. This Andhi will go, settle down, or what happens?
There are only 2 schools of thought. You can be mechanical or you can be true kinematic.
I will just,
No,
very correct.
If you look at the data provided by Howell, you will find he has better survival rates than mechanical, and he has specifically quoted Reiter and Perrette in his papers, because these were the 2 people who published retrospective data of their mechanical alignment series to highlight the fact that if knees are going beyond 3 degrees, they fail miserably.
Yes, Stephen
and
Howell.
He specifically mentions that.
Stephen Howell has a credibility issue as well.
Knees that were outside these axes are still surviving 98%.
Stephen Howell has credibility issue as well. So let's not talk about that. I think just one concluding remark on this session is that go to a Mayo Clinic paper on 20-year follow-up of the alignment, studies. And they had many outliers beyond, say, 3 degrees and 4 degrees of varus, and they were not failing because they were well balanced. So well balanced knee is critical. The alignment is not so critical an issue. I think on that note, we should conclude this session.